Welcome to Vale la Pena. In English, that's worth your while. I'm your host, Cynthia Ribas. This is a show where we get to do some grassroots philanthropy together. In all episodes, we'll feature nonprofit organizations engaged in inspiring projects for people, animals, and the environment. Some guests will be representatives of those organizations, and they'll share with us more about initiatives they're working on and ways we can participate. Check the show notes for opportunities to impact these humanitarian causes together. You can find this show through my website at www.rebuslegal.com and on YouTube, Facebook, Apple Podcasts, Spotify, Google Podcasts, and more. Now, please join me for Vale la Pena. Hello! Welcome to Vale la Pena. Thank you for tuning in. If you've been listening, you know our show is committed to grassroots philanthropy. And the idea is very simple, and it's that we can make a bigger impact together. So the way we do it on the show is we have guests and engage in conversation that we hope you will find inspiring and interesting. And in all cases, we spotlight nonprofits. So if you are moved to participate in any way, the show notes will give you all the direct links so you can engage in the nonprofit organizations that we spotlight. Today's guest, I am so very honored to introduce to you, is Dr. Perry Fine. He is a medical doctor, specialty anesthesiology, subspecialty pain medicine, hospice, and palliative care. He is also a professor at the School of Medicine at the University of Utah. So without further ado, let's introduce Dr. Fine. All right. Well, I know another specialty of yours is pain medicine and pain management. Talk to us about that.
Well, I tell you what, let's dive in to the deep end head first. I've got this little piece of paper here that I wrote down a quote from as I was looking through the news today. And I think you'll get a sense of one of my big social concerns in the area of pain medicine. This was published today in USA Today by Singer and Bloom. And here's sort of the headline as they sort of laid out. Thanks to pressure from lawmakers, government agencies, and policymakers who inserted themselves into the patient-doctor relationship, patients became the victims of the never-ending war on drugs. And what they're referring to is sort of the opioid crisis as it's played out, where the abuse and addiction communities, obviously nobody should belittle or marginalize the toll that drug abuse has taken on people's lives throughout history, but accelerated in the last 10, 15 years as opioids became sort of the drug of choice. We went from, in the first 20 years of my career, cocaine, methamphetamine, hallucinogens were sort of the drugs du jour. And then in the early part of the 21st century, opioids became more available as concerns about undertreatment, especially of patients with cancer pain, became a big public health effort. And so people sort of became more aware of those. And so pharmaceutical availability did increase. But as it turns out, the overlap of people with legitimate, if you will, or credible medical need for with intractable pain conditions, who had where opioids are an irreplaceable part of the toolbox It's certainly not all there is. There's a lot of other things, and certainly opioids should never be prescribed without sort of a comprehensive understanding of the patient and close monitoring and follow-up, just like we would with chemotherapy or any other area in medicine where there's tremendous benefit, but also potential for tremendous risk. But as a result of abuse, misuse, and a perfect storm of a lot of components under coverage by insurance companies that would not cover comprehensive pain care, inadequate education at the undergraduate and graduate levels in medical training. Simply, pain is one of the biggest public health problems we have. And in fact, I'll back up a second, and it'll surprise probably your listeners and maybe you, Cynthia, although I think you've probably heard it all and nothing would surprise you anymore. But if you add up the direct and indirect costs of pain and persistent or recurrent pain as a driver in healthcare, people who are suffering this, and the costs of both missed work as well as medical care and so forth, the overall cost to our annual GDP, the annual budget of the country, expenditures, exceeds cancer, cardiovascular disease, and diabetes. Each one of those, which are mammoth, but that's exceeded by pain. And pain is pretty much the number one reason people seek medical care. It's a huge problem. And we've got a long way to go to get better at understanding medically, scientifically, and safe ways of treating pain. But the point that this article made, and which is something that's been clearly on my mind over the last decade, is how patients who really have credible and important critical medical need for pain management and where opioids play a role have been completely marginalized and have been, in fact, have suffered enormously. And the suicide rates for patients with chronic pain conditions have skyrocketed. It's not been talked about, poorly publicized. People are largely unaware of this. So it's sort of a hidden epidemic. And since all of the efforts to curb the quote opioid epidemic started up about a decade ago, the net result has been not a reduction in opioid related mortality and opioid overdoses and deaths. It's actually doubled. So, it's clearly not coming, and opioid prescribing has been strongly curtailed because of fears of prescribers shutting down of pharmacies, refusing to prescribe opioids, refusing to dispense them, fears of litigation, of being sued, all that stuff. That hasn't been the driver. The driver has been continued to be abuse. Now, clearly, we've moved away from availability of prescription opioids now to black market, and especially fentanyl. And now fentanyl is lacing everything, and there's been a big resurgence of methamphetamine being laced with fentanyl. But those deaths have skyrocketed. And so who's been left behind? The patient with a debilitating, intractable pain problem, and the physician who wants to take care of them has been left oftentimes without the tools to do so. So sorry, I'm on my soapbox here, but it was very timely because that article came out. And I would say that, if you look at the perfect storm of why this happened, certainly the zealots in the addiction community thought that it was all pain that was driving this, and the people who are trying to be proponents for and advocates for patients with pain, those individuals end up with no accountability now for their actions, have really caused tremendous damage to that population. So we, misinformed patient advocates who thought that they were saving the world from quote opioid addiction, and all they were doing was leading people to suffer horrible lives without help. And then, last but not least, Cynthia, maybe you can speak to this a little bit from your perspective as a legal professional. But this became a tremendous boon for mass tort law firms who saw this as being an opportunity, like the tobacco litigation, to basically create a case that opioids had no value and no purpose, and were only harmful, and then could create discovery and look for malfeasance within pharmaceutical companies. And believe me, there's no shortage of I think, there's plenty of little smoking guns within the drug companies, just like there has been within the tobacco industry. The difference is that opioids do have a critical therapeutic role to play, and have been prescribed safely for millions of individuals who don't become addicts, who don't get into trouble. But it does require education, knowledge, skills, and a practice and structured practice environment where you can manage this care effectively and safely. I'll take a breath because that's sort of a long, just expository, and let you sort of poke away at some of these arguments or see what other things you might find to talk about here.
Well, I'm interested in how the U.S. is doing in terms of the opioid crisis as compared with other parts of the world. Is there an increase in addictions and deaths that are correlated with opioid abuse everywhere, or?
Not nearly what we found in the United States, which is actually a really important and really, not to butter up the host here, but that's a really an insightful question, because in other countries that have not necessarily have been as open to prescribing, but certainly have not been horribly restrictive, there has not been the mortality and opioid deaths and people dabbling, and in spite of knowing how harmful it can be if you aren't in a controlled medical environment or prescribed and use only as directed and those sorts of things. The United States really is an outlier. And, sociologists have started to look at this, and I've been thinking about this for a long time. And we sort of have created a category of sort of deaths of despair. What's going on in the United States that have led people to feel that life, without being altered, but in an altered state. I'm not talking about pain management now. That population can be managed effectively, but the multiples of individuals who are misusing, abusing, taking their stuff from the medicine cabinet prescribed from others, going to parties and just taking handfuls of pills, obviously theft and and all that, and then the whole black market that's built up of fentanyl products from that have been imported. What leads people to feel they're willing to basically play Russian roulette every day? I don't have an answer for that, but I do believe that it requires a lot more reflection and real failure, I think. Not that government is the answer for everything, but if we look at government as being sort of the primary sort of unifying entity that looks after those potential harms that can bring down a society, and whether it's from military efforts from afar or whatever, the things that we always sort of conventionally think about, we're killing ourselves at a rate much greater than our worst enemies could imagine doing to us. And it's all self-inflicted because people don't see their lives as potentially valuable enough. They don't feel connected. There's a whole lot of reasons for that. The news over the last couple of days, I'm sure your listenership has been hearing, is that 1 out of every 3 teenage girls has entertained suicide in the last year. So, mental health and feeling sort of the life reflex that we're sort of born with has dissipated. And this is just maybe a very strong signal. And this is maybe the mechanism by which people try and relieve their psychic pain, their existential suffering by using these drugs and then ultimately overdosing. But we do, again, a bigger issue than we have answers for in this discussion, but I at least it should be raised to people's attention. And the least of us to be victims of all of this should be somebody who has a medical condition that now we push them towards suicide rather than pushing them towards living a life that feels ample enough to want to wake up and day after day after day, because their pain is no longer so severe and distressing and life limiting.
Well, this little podcast has big ambitions, and one of them is that by talking about these issues and coming up with opportunities for people to participate, some of that might help give people ways to connect, because we definitely have problems with isolationism, and everything I see are just skyrocketing levels of depression and suicide ideation. And I think the pandemic, with all of the shutdowns, made some of that worse. But we've had issues of connecting. I think the technology plays a role, keeps us, even when we go to board meetings, people are looking at their phone and not talking to who's in the room. We get a lot of factors that are affecting our ability to be with one another. So part of what the show notes aim to do also is give people opportunities of, obviously, financial donations are welcomed, but also many of these organizations that we highlight also provide many opportunities for people to participate on a volunteer basis. Because I think, as this particular podcast has really shown, we're also multifaceted. Music plays a role in our lives, our professions play a role in our lives, and we all care to make a difference and get out there and do something. Back to the opioid crisis or pain management. Is there somebody doing anything right out there? Like, who could we look to learn in terms of solutions that might help us start to tackle the problem?
Well, in everything sort of in micro ways, certainly at the University of Utah, our division of pain medicine is vibrant. When I started, I was the second faculty member who had a special interest and had gone away and done a fellowship and trained specifically in pain medicine, and then came back and was recruited back to the University of Utah. It's a little over 40 years ago now, specifically to develop the pain program. I now have, the person who preceded me is retired. So I'm now the senior guy. I still do see a small group of patients with chronic bad diseases where pain is a big problem. But I'm the oldest guy by 20 years. I'm 70. The next person in line is 50. So we've got a whole generational gap. But after that, between, say, ages 35 and 50, we now have a faculty of 12 physicians, plus nurse practitioners, plus psychologists, behavioral specialists, physical medicine folks, functional restoration, physical therapists. So we work in this interdisciplinary way to help people rebuild their lives. So we integrate medical, behavioral, functional. We don't get a lot into spiritual issues because that's sort of not our thing, but that could certainly play a big role, like it does in hospice. Because people do ask those questions, why me? And, is there, something out there bigger than me, or is it just me? And all these sort of existential questions. But we just pretty much try and help people to find life worthwhile by focusing on relieving their pain to the extent we can, and then helping them to rebuild their lives. These programs like ours are very far and few between. There used to be a lot more of them. Insurance carriers basically swept them away, said it's not worth our while because everybody looks at immediate returns rather than long-term. And this is a long-term investment. And, what happened in our healthcare systems is, you might be your carrier might be company X this year and company Y next year and company Z next year. So there's really no long-term investment in preventing the kind of costs associated with poor treatment of conditions like chronic pain. So these kind of interdisciplinary programs have largely been swept away. And that's a big problem. But there are other programs. My colleague, Scott Fishman, Dr. Fishman, and He's a professor at University of California at Davis. Is avidly working. He's a pain medicine specialist, but he's now working through on education programs to try and help primary care physicians be far more knowledgeable and skilled at managing, diagnosing, and treating, and early recognition of pain problems that may become intractable and getting early intervention. He's working now with the Centers for Disease Control and Prevention, CDC, which some would say was part of the problem because they created some guidelines that were horribly misinterpreted that was added to some of these problems that pain patients have. They've tried to rectify some of this, but they're actually interested in some of the maybe broad-reaching national education programs to help with knowledge and education and skills. And we're looking to be part of that, University of Utah, with this is sort of not, it's in the early phases of development now, but some centers of excellence around the country. But there are programs like that that are now blooming, but it's largely out of some, very strong-held motivations by certain individuals. I think that the whole area of pain medicine really skidded to a horrible, abrupt halt with the opioid crisis. Everything that was attached to pain was attached to opioids, and everybody sort of ran away from it. And that just basically it destroyed a lot of the professional organizations. There was an organization called the American Pain Society that was interdisciplinary, medicine and research and nurses and social work, etc. That basically they became named defendants in lawsuits with no justifiable reason whatsoever, other than as a strategy for a big, in my view, a big payday by the litigants, without regard for the sort of related damage that it could do. So that organization's dead. It died 3, 4, 5 years ago. And that was a group that was avidly interested in and helped try to develop policy. Most of it had nothing to do with opioids. It was around all the things we're talking about, how to help people rebuild their lives and to connect with with health and wellness rather than with waiting until people were so sick and there was no and leading to hopelessness. So that organization died. The American Academy of Pain Medicine, which is largely physicians, and I was sort of one of the sort of founding members way back when. That organization has struggled and has almost gone bankrupt, and for similar reasons is trying to rebuild itself. And but anyway, I think we've gone way off the rails as far as helpful, policies that could be helpful. And COVID really, sadly, it wasn't I think everybody's now would blame everything on COVID. These problems existed before COVID. It wasn't just 3 years ago these issues came up, but COVID, I think, as you were alluding to, iced the cake. It created a lot more isolation. Funding for things went to other directions. Much of it, very much needed, but it was in a way a distraction from the other key issues that we're facing, and this sort of culture of despair that had sort of taken over in many ways. But I will make one comment that's an observational one. I'm not a politician. I have no interest in being one. I love being a physician. I love closing the door and trying to help a person rebuild their lives in one way or another. But I think our politicians have really dropped the ball on this. These are not partisan issues. There's nothing partisan about this. It's not liberal. It's not conservative. It's not left. It's not right. It's not, if valuing people's lives to the extent that we can and living as well as we can is somehow radical, then boy, we are living in radical time. But it's complicated, and it really takes time and effort, and it's not sexy. It's just grassroots work at trying to understand people and helping communities figure out ways of not spending more, but taking the resources and allocating them in ways that can be helpful. And, there are a lot of aspects of this: homelessness, obviously substance abuse, which we've talked about, and there's an intersection, mental health, and there's an intersection, and underemployment and compensation. So you can work 3 jobs and still not be able to raise a family, all these things. So anyway, it all does impact on medicine. Our hospitals become overwhelmed, our healthcare systems, because we catch people in the extremes rather than, the beginning. And preventative medicine is not sexy. It's not heroic. You never put out the fire that never starts, right? But anyway, you get the drift of where I'm going with this, I guess.
Right. But I like that metaphor of the fire. I do think I like also the interdisciplinary approach. I do think we need to be working on figuring out how to keep people's sense of self and spirit thriving, a greater respect of life. This, what you refer to as deaths of despair, that's a whole other sort of quiet tragedy in our midst that we're living with. And there may be things we can do in terms of, short of obviously expertise at your level, but even just, as you mentioned, nonpartisan, but public health concerns, person-to-person issues, community efforts. I know, in terms of homelessness here in Los Angeles, where I live, that is a grave issue and very complicated issue, and where they're finding best success is when they have interdisciplinary teams looking at the various components of how and why it is that we have so many people living on our streets. Well, Dr. Fine, I can't possibly thank you enough for giving us some of your time today. Do you have any final words that you would like to say in closing?
Well, yeah, I don't want to leave everybody feeling like this is hopeless, and I still am smiling. I'm maybe a pathological optimist here. I do see hope. I do see some rays of sunshine here and then, and where I see it is because if you open your eyes, there are a lot of people who are very interested in trying to rebirth community. I'm not sure what the most bite-sized piece would be, but as soon as there's more than one person in my family, there's 5 opinions. But we got to learn how to, not kill each other over those opinions. But maybe with the expansion of our societies and more urban, it's not an urban problem. Clearly, it's a rural problem too. And in fact, some of the rural areas in this country are the most hard hit by this stuff. But I want to bring this back to what we started with, which is the arts and creativity. I think one of the most extraordinarily healing aspects of what human beings uniquely have is without necessarily having special skills as an artist or musician, we're all creative. Everybody has a story to tell. Everybody can draw a picture. Everybody can play the most basic, we start kids on little flutophones, everybody can do something, and it does bring joy. And it sounds superficial and trite, but I would just encourage everybody to take a step back and think, what can they do? We talk about journaling and all this stuff, but that's sort of, we get so narcissistic and belly button gazing and stuff. Just express, figure out a way of spending 15 minutes a day, even just like exercise. It's obviously diet and exercise, we always talk about it, but how do you help people get there? But I would say the third spoke of that, leg of that stool would be do something creative that just feels good. It's not like practicing a violin where it sounds horrible and you're doing scales or something. Just do something that feels good. And all of a sudden, when you realize, this is another really wonderful aspect of being a human being, is that time, it truly is relative. When you're doing something joyful, time passes by and you don't even know that's the zone, right? When you're suffering, time takes for every second of the clock, like Ingmar Bergman in his, existential films here, every tick of the clock. So figure out something to do that takes you outside of yourself, and creative ventures, I think, is one. And even if you don't want to do something yourself, then there are a lot of community theaters and musical events or whatever. But anyway, that's my, humble words of wisdom for, to take with you. But thank you, Cynthia. I really appreciate the time meeting with you and your listenership. I hope people got something out of this. I really do.
Thank you so much to everyone listening. Thank you, Dr. Fine. I hope it's been worth your while, and thanks for tuning in. Thank you for tuning in to Vale la Pena. Please join us in making an impact together for people, animals, and the environment. Details in the show notes. You can find this show through my website at www.ribaslegal.com and on YouTube, Facebook, Apple Podcasts, Spotify, Google Podcasts, and more. I'm your host, Cynthia Ribas, and I welcome and thank you for your feedback, comments, questions, and sharing this show with others.